Today on the 229 podcast.
Instead of doing the same with half the FTEs, you're doing 100 times more with twice the FTEs.
My name is Bill Russell. I'm a former health system CIO and creator of This Week Health, where our mission is to transform healthcare one connection at a time. Welcome to the 229 podcast, where we continue the conversations happening at our events with the leaders who are shaping healthcare. Let's jump into today's conversation. All right. This is another 229 podcast, and today I'm joined by John Lee, practicing physician, also the founder and probably lead consultant, if I thought about it, of HIPP Advisors, where it seems like you're really focused on Epic. Are you really focused on Epic for the most part?
Yeah, and I think I have some other competencies, but
I know you have some other competencies, but that's when people seek you out, it's predominantly to help in that.
It's my easy place.
Well, we ran into each other at UGM, and this whole episode is going to be about UGM. We're going to talk about, because you're one of the people who probably posts, I would say, if not the most, a fair amount about UGM and comments on other people's things. So you've probably read as much as I have. You have more access at UGM than I do as a practicing physician. Of course, they give me a red badge. So everyone knows, they know I'm media just by the red badge. And then I have an escort the whole time I'm on site, which I perfectly understand.
Did they want to put it like a red A on your chest too?
When they first gave it to me, I said, is this like the scarlet letter? And they looked at me like, that's not funny, man. I'm like, okay. No, actually, they're great hosts. They give you somebody to be with you all day. They answer all your questions. They make sure you don't get lost, because it's a place you could get lost at very easily. But I understand it's the Epic user group meeting. It's not a conference per se, like we would think of other conferences. It literally is a user group meeting.
Although it's interesting how it has transformed over the past 10 years. I remember when I first started going there 10 years ago, it was me and my team, and we'd go to the UGM, and then we sit in our hotel and we think, oh, where are we going to go to dinner tonight? And then maybe watch a movie in our room. And now it's not quite HIMSS or Vibe, but it has a lot of those same vibes.
Yeah. I mean, the number of people down in Madison was pretty significant, and that tends to be the place people go. And then invariably you have a dinner with some of your Epic people while you're there as well. I want to talk to you about that. I mean, I don't know if there was more announcements, but more announcements that people wanted to talk about than any year I can remember. Obviously, a lot of AI talk. Let's start with the positive. What impressed you the most about what you heard?
Well, if you know anything about me and what intellectually interests me and what I post a lot about, you're not going to be surprised that the thing that bugged my eyes out most was all the stuff about Cosmos.
Yeah, I agree.
And I remember talking at UGM in 2022 about Cosmos. And back then it was essentially they were what they call their slicer dicer product. And I talked a little bit about how I envisioned where it would be going. And they are definitely going in that direction. And it's mind-boggling to me how fast they got there. And it's interesting because last year I thought they were just slowly easing their way into it. And then all of a sudden this year, just like hockey sticked up in terms of the things that they are envisioning how it will work.
Yeah. Well, I mean, think about the data set they have to work with. It's staggering. It's 300 million patients, I believe. That population set is just massive. Number of encounters, all the data. And what they showcased was pretty interesting. Essentially, almost a partner, if you will, for the clinician as they're doing things. Say, hey, consider this, and I've looked at this record, or I've looked at this additional information. Perhaps this is something else you could look at. I mean, are we looking at the future of medicine, essentially a trained physician or clinician and an AI partner?
Yes, and actually probably even more than that. So I posted about this in my most recent Substack, and it was a summation of my presentation back in 2022. And if you look at how we took knowledge in medicine, famously, there were a bunch of studies that showed it took about 2 decades between you discover something and it actually becomes common practice in medicine. Now there is a mechanism, number one, to come up with those insights way faster. And also because Epic owns the platform and the ecosystem of both the discovery and the execution of that discovery, theoretically, it can actually be systematized and appear in our workflows way faster than that. I think that's generally where they're trying to get to.
You weren't bold enough, and I'm going to push you to be a little bolder here. So your quote is, maybe we can reduce the adoption lag of new insights to practice to something shorter than 2 decades. You want to predict on how much shorter than 2 decades we're going to be able to get to?
You know, honestly, I think ultimately where we're going to get to with this is the limitation is going to be our own mental inertia. I could, at least from a technical perspective, I could see something being surfaced up in Cosmos, new insight, and then getting it into the system operationally in hours or days. Now, you want to be careful about that, and you want to do governance, and you want to make sure that you communicate and all that. But really, it's the rate limiting step is going to be all those governance cogs in the wheels. And yes, you do want to have that, but I think we're going to have pretty significant transformation by orders of magnitude in both knowledge discovery and incorporating that knowledge discovery into our workflows.
There was also an announcement about their own foundation model essentially on top of this data, right? So developing essentially an LLM on top of this.
So it's basically a transformation of that content of the raw atomic data and processing that content into nuggets of data that is far more interpretable, semantically meaningful, and things that an operator or a clinician could actually work with, rather than, say, a LOIC code or an ICD-10 code or some sort of obscure flow sheet.
It's big data at the scale of a country, essentially. So we used to be able to, as a health system, look at bringing all that data together and getting insights and whatnot. But now you're looking at insights across, again, 300 million patients and how many different encounters. Mm-hmm. And the foundation model becomes a way to tap into that fairly easily. And I assume it's not that hard to layer in research studies, case studies, all sorts of other stuff on top of that.
So one of the things that I talked about in 2022 when I did my talk is that imagine if we could meld Facebook and New England Journal of Medicine so that I come up with some sort of insight. I did it in Cosmos. I put it out there on some sort of medical social media site and say, hey, I discovered this. These are the insights that I had. And if you have access to Cosmos, here's the hyperlink to my query. Take a look at this. Tell me what you think. And then a colleague comes in, oh, you're way off. You did this query wrong, or the way that you pulled the data was incorrect, or you forgot to take into consideration this other data feature. And then I ran the query again, and this is the sort of insight that I got. And so what you could then start doing is having this iterative back and forth so that if you think about it, then you can have a knowledge flywheel come up out of this that's far more nimble than collect a bunch of data over 3 years, curate that data, wrap some statistical layers around it, spend a few months writing stuff into a paper, sending it off to a publisher, have them do some sort of peer review on it, have them come back to you several months later, and then all told, it takes like 5 years from start to finish. Whereas I could do a query in an afternoon, come up with some sort of insight. Somebody else can do another query in the next afternoon. And granted, some of our processes and the way that we curate the data and do the statistics may not be up to the level of an academic medical center. But then if you have crowdsourcing and layered on top of that, you have all sorts of other mechanisms to correct, refine, and polish those sorts of insights, and hopefully come up with something even faster and better than what we have right now.
Again, you had more access. You talked to more people. I'm curious, you're talking about doing queries against the data, which is very deterministic. It's a deterministic way but we know that foundation models work a little differently in how they store and retrieve knowledge and whatnot. And that's what leads to hallucinations and those kind of things. Was there a lot of talk around hallucinations?
Actually, not much. I think the general broad terms of the talk around the conference was simultaneously on one side, lots of utopian talk about like, oh, now we're going to fix healthcare, and a lot of evil empire Death Star talk because they're taking over everything. And do we really want this?
Right.
And sometimes people would say both out of the same mouth.
If anyone's proven that they're not, I mean, they're not an evil empire, it's Epic. I mean, they've been a really good partner to healthcare over the years, but I do understand where that talk comes from. And part of that is some of the other AI announcements that came out. And my gosh, you would think they had obliterated a bridge and ambience in their business models and whatnot. And I talked to founders of both of those companies while I was up there, and they're like, look, nothing's changed. We still have access to the same workflows, the same data, the same whatever. We have a proven client base that we're working with. We have things that we differentiate from them, and we have different directions that we're going. And it's like nothing's really changed, except everyone's used to, well, Epic has decided to get into this market and they're going to own the market, essentially.
Right. So what in the run up to this, and I'm sure they did this leak on purpose, there was this sense that, oh my God, Epic is going to come up with their own ambient documentation that's going to put everybody out of business. And what the truth is that they were still going to do the same thing that they've always planned on doing, wrapping the transactional presentation layer of how to actually deliver healthcare and have some sort of AI or ambient technology underneath to help drive that. Basically, what they said is that their favored engine in that EMR chassis is going to be Microsoft.
Right.
And you could theoretically then take that engine out and put the ambience engine, or take the Abridge engine. And so I'm not saying that it's going to be completely equivalent. I fully expect that Microsoft is going to have some most favored nation sort of access to the content and the tools within Epic. But there's plenty of room for Suki, ambience, and Abridge.
I don't remember if it was last year or the year before, but when Sasha got up on the stage, I remember leaning over to the person who was my escort at that point, and I asked her, I said, wow, it's pretty normal for somebody from one of your partners to be on stage. And she said, I don't recall it ever happening before. And I thought, oh, that's a big deal. Like that's, and what I thought at the time was that signaled that Epic was going to be more of a partner, and they were going to look to partner. And that year we saw some significant partnerships with those players that we've already mentioned, where they said, okay, we are going to partner with these specific players. And if you talk to the Epic people, they will say, we would love to partner with everybody, but we don't have the resources to partner with everybody at this level. It takes a lot of resources for them to work with them and to integrate it and whatnot. But I thought it signaled, hey, we are a partnering organization. And clearly for Microsoft, it meant more than that. I mean, they were able to drive a relationship, I think, that is a pretty enviable relationship in the industry.
And I think, just from my perspective, it's a defensive play both by Microsoft and by Epic against Oracle.
Oh, interesting.
Because I have no direct knowledge of what exactly Oracle is doing. But just from the rhetoric that I hear, and just from the wisps and communications that I have with people who are in the Oracle space, they're building everything up from the ground up. None of this bolt-on Saurian or this revenue cycle thing or add on this lab information. So everything is whitewashed. This is what we're starting with. We're going to basically create an AI-based version of a full enterprise solution, basically like what Epic did. Now, do they have the runway to do that? I don't know.
But you do know. I mean, so I was asked 2 days, and I can do this because essentially I don't get paid from anybody to do anything except give my opinions. But somebody asked me the other day, it's like, do you think Epic's being defensive against Oracle? I'm like, this battle is over. Because to switch from one to the other is way too prohibitive. And they just landed Intermountain, Northwell, and UPMC. I mean, these are the last of the holdouts.
Of the big server organizations.
Yeah.
And especially Intermountain. I mean, they were a development partner of the old server.
Yeah, every children's hospital I know of has said, okay, we're going over in our meetings. So we do our 229 meetings. We have 15 leaders in the room. My first question is always, all right, what EHR are you on? Because it matters, because Epic sort of changes how people approach certain problems.
Right.
And it's only like one or two people left that are on Cerner. And to be honest with you, certain meetings, we have more Meditech than we have Cerner in the room, because Meditech has at least a spot that Epic hasn't really gone after yet, which is a fairly low cost complete system, although they're now doing a ERP and whatnot, which is one of the things that, that Meditech had going for it. It was a complete system from end to end from that perspective. I want to talk about the state of Washington. So that to me was another one of those announcements that I sort of sat back. Well, you had the country of Singapore. I think there was another country, and then there was the state of Washington. And I sort of sat back and I thought, yeah, this is really interesting. State of Washington specifically to me was one where the state said it's worthwhile to subsidize all the remaining players in this state to get on the same platform, because it really solves their interoperability problem within the state. And it addresses public health data flowing up to the state. It also addresses fraud, waste, and abuse, because you have a lot more transparency and visibility into what's going on.
You can normalize a ton of data.
Right. And it could potentially address the opioid crisis as well. I mean, there's so many things. Like after they announced that, I was just sitting there going, that might have been the most compelling announcement to me. And I could see other states going in that direction.
Well, and if you think about how Epic works transactionally and what the data layers look like underneath, it makes total sense. You do have to take a bit of a both financial and operational leap and risk to do this, but I totally get why organizations do this. I am firmly in Camp Epic. That's where my entire career is around, and I feel the most comfortable in that system. But I really do hope that Meditech, Oracle, they still have a substantial presence, because we can't just have one.
I'm with you on that. And I was asked this week, why don't they face more monopoly kind of things? Why don't they face more of that rhetoric? I said, well, there's two reasons. I'm going to give you two reasons, but I haven't really thought about it. And I haven't really thought about it much since then. But the two reasons I gave were, number one, they haven't bought anybody. They like grew it organically. Like every other monopoly you know of, they just bought up the competitors.
Right.
And that's how they created their monopoly. Well, so they didn't do that. So it's not as clear cut like, hey, they bought a market. They didn't buy a market. They earned a market. All right. So which gets to the second thing is, you have all these health systems on there. And if you bring up monopoly in front of them, they will essentially say to you, they're our best partner, like by a long shot. Like we like dealing with them. They're not perfect. And every one of the leaders I work with will tell you where they're not perfect, but they'll say, look, they're the most fair with pricing. They could up their price. They could double their pricing and no one's going anywhere, but they don't do that. They listen. Like when they roll something out and say, hey, this is what we're going to charge for AI, and people give them feedback, they go, oh, okay, we see that, we understand that, and they adjust and they listen. They have a good relationship with their clients. And this is not an exaggeration to say, on a scale of 1 to 100, like Epic is in like 90 plus in that scale of valuable partners and partners they like dealing with. The next closest one is down at like 70. It's just a different dynamic that they've been able to create. So they haven't bought the market, and they have nothing but fairly happy clients. None of their clients are clamoring for them to be broken up as a monopoly. So that's the reason
But their competitors might start.
Well, sure. I mean,
and I think, well, no, but to that point, for instance, at least from what I can tell, Oracle probably has some outsized political clout. And I think they can probably, if it gets to a certain point, they can start turning some political thumbs boots. I don't know anything about any inside baseball. This is just me as an outsider saying.
It's just two people talking on a Friday afternoon. They do have a lot of government contracts, and Epic has, as far as I know, they may have state contracts, but I don't think they have any federal contracts.
And so here's where I think Epic can inoculate itself against any sort of antitrust. If they give something back, particularly to CMS, if they start creating some programs that makes some pretty significant progress on the Medicare CMS spend side of things.
I agree.
And then be able to say, look, if you break this up, this solution that we have in for you that is saving you billions, if not maybe even trillions of dollars, it's going to break.
Yeah. So I want to go down, there's a couple paths. I want to close this by asking you, all right, you've walked away from UGM before as a clinical leader. How do you make sense of all this stuff? How do you determine where you're going to go? But before I get there, I want to talk about Jevons paradox. So you have a great line, and I used your line in one of my posts because it is such a great line. CFOs are sort of drooling over AI. They're looking at it going, oh my gosh, I'm going to be able to cut 2/3 of my staff out of rev cycle. I remember the first one because it's so funny. It's like the first thing you need to do is get a soul transplant or something to that effect. What was the second one?
So it's that they don't understand that it's not just about staying here. So this is, let's say these are your like HR costs.
Yeah.
And this is what you're able to maybe not financially produce, but be able to deliver in terms of healthcare. So instead of staying here in terms of what your delivery is and reducing your costs down to here and make more of a profit, what I would say is actually increase and then take this and make it way higher. If you have not been actually involved in healthcare IT, you don't truly understand that there's probably 80-90% of the stuff that we want to do that we can't do.
Right.
And that we know can make a huge difference, but we just don't have the bandwidth. Now, imagine if we had that extra capacity, then all of a sudden, yes, we can do all this. Heck, we want to do even more than that. So when you see examples of Jevons paradox online, there's all sorts of examples of people thinking, yes, this will make things more efficient, so we'll be able to reduce the resources, but the resources end up going up because people see so much more value out of it that they just funnel even more resources. So that instead of doing the same with half the FTEs, you're doing 100 times more with twice the FTEs.
Right. We have a big barrier between here and there, and it's trust, right? So it's clinician trust of AI models. So I've interviewed just a whole bunch of people, UCSD, Stanford, and others, about adoption rates of these AI models. I trust them in rev cycle. I trust them, and even in IT. I mean, I would be deploying AI all over the place. From a clinician standpoint, it's almost like you're onboarding a new staff member, and people have equated AI to that eager intern. Are we past the eager intern and the person who's going through residency, or are we at a point where it's a valued partner that I can trust?
We are definitely at that point. Because if you look at some of the generated summaries, that is just enormous.
Yeah.
Because the time and effort it takes to conceptualize all the stuff that happens during, say, a hospitalization between visits and come up with some sort of very succinct messaging to the end user, be it a physician or a nurse or whomever, make it so that they can look at one document and get 90% plus of what they need just from that synthesis.
Yeah.
Is huge.
I remember talking to Andrew Rosenberg when the large language models were just coming on the scene. I said, what do you think the killer application is? He said, complex patient chart summaries.
Yeah.
Because some of those things can take days, literally, for people to pull together and summarize. And if we
and it's not just the actual effort, it's the emotional angst of, oh God.
Yeah.
And now it's just, you press a button and it's there. Maybe you have to polish it up a little bit, but it's fantastic. Touched on it a bit, and I don't think it has gotten the hype that it actually deserves. I personally think the killer app feature of Cosmos is the Cosmos Medium 9%.
All right. Why? I'm trying to think of the easiest question to get more out of you on that.
So right now, what ends up happening just at a high level is that patient comes in, say, for pneumonia. You treat him, you send him home, and then let's say there's a whole bunch of other similar pneumonia patients. You treat them, send them home. After all the coding and processing is done, you get a geometric length of stay and you get some sort of assignment of, for this particular patient, you were given 2.5 days, and the patient stayed for 4 days. You incur 4 days of cost. Too bad, you suck. You only get 2 days of reimbursement. So the problem with trying to fix that, to try to fix the processes, is that instead of getting that length of stay report after all the coding is done, you want it early on.
Right.
So that you can actually then adjust some of your processes, operational processes. And if you talk to patient flow people, that has been the Nevada State and what they've been wanting for like literally decades. There are some third-party vendors who actually provide this, but you have to actually pay for that. And on top of that, they typically only provide you that information the day after the patient is hospitalized. Cosmos median length stay, as soon as you hit that ADT order, it will give you that information like that. You don't have to accept it. You can put in some other number and say, you know what? Cosmos median length of stay is going to be 3 days, but I know that the patient is actually going to stay for longer. So you can put that in, and then your patient flow teams can adjust based on that. But I kid you not, when I talk to some of my inpatient colleagues about this, when the providers are forced to put in a length of stay, there are docs that I know who will just passive aggressively put in a length of stay of 1 day for every single patient that they have. There are others, someone told me that there's somebody he knows who puts in a year length of stay for every single patient that they have. So how can you operationalize any sort of patient throughput based on that?
We're getting to a point. So it's interesting. If you talk to some of those other players, the Bridge, Ambience, and others, where they're going is essentially real-time information to the physician at the point of care. So, hey, this is how this is going to be coded literally as you're the patient sitting across from you. So you can look at that and go, oh, dang, I should have ordered that test, or I should have done, because you're going to have that information at that moment. You had a Bridge actually saying real-time prior auths. It was their announcement just prior. And so they're doing that with Highmark, and they're in negotiations with a couple other national players to do real-time prior authorizations. Some of the things that caused significant inefficiencies in the process because we didn't have the information until much farther down the road are now being moved up to a point where you can actually do something about them.
Yeah. So imagine if some future state where you feel confident that the prior auth information surrounding the order was accurate. Let's say you're in for really bad back pain, you're having radicular symptoms down one leg, and that the back specialist can then order that MRI and tell you, go to the front desk when you check out. They'll schedule your MRI. Oh, look, Bill, there's an opening in about half an hour. Why don't you just walk over to the MRI and get your MRI done right now? That's the sort of transformative workflow that I think will start occurring.
So adoption is so key. Maybe this is the norm. I'm not used to it. They announced so many new things, so many new features, so many AI features alone. How do you make sense of that? Does anything really change, or do you still go back to your health system and say, hey, this stuff was announced, but we're still working this set of problems that we've been working, and we're just going to apply these tools to the same problem sets?
So I think one of the things that has occurred across the entire Epic ecosystem is that Epic organizations are trying very hard to move back to as clean a slate, close to what they call foundation.
Yeah.
If you're close to foundation, essentially new stuff comes on, it's basically like throwing a light switch. You don't have to configure a whole bunch of stuff. You don't have to do a lot of validation. It just works.
Be careful turning it on, because now some of those measurements are based on adoption, not just turning on features.
True. And I have my issues with their whole gold stars and honor roll. It, to me, starts smelling a little bit like the Joint Commission inspector coming into the hospital, and then you're cleaning everything up, and then everything's pristine, or Leapfrog coming in, you're turning on all of your medication alerts that everybody ignored. it works, and then you turn them all off as soon as they leave.
Yeah.
A lot of those metrics, I think, make people study for the test and perform to the test. But what ultimately needs to happen is that we just need to use the tools to do all the right things. And that's where I think, to what we talked about before, ethics is very aligned with organizations in trying to accomplish those sorts of things.
Yeah.
They fully view the gold stars and honor roll as tools to help nudge wayward organizations to, hey, help us help you. But ultimately, especially if you're a high performing organization, they tend to become, I think, less relevant.
How do you make sense of this for the organization that you're sitting in front of?
It's hard, honestly. You have to figure out where the bang is for the buck. And it's going to be very difficult to synthesize value versus cost, not just licensing costs, but also operational resources.
Yep.
And I don't have a magic bullet for that. I suspect that everything, as is usually the case, is going to be based on what will provide the most immediate revenue or increased savings versus the other stuff.
Yeah, I agree. I didn't articulate it well, but that's what I mean by nothing's really changed. I mean, you're still sitting in the executive meeting and they're saying, look, we're at 1% margins. We've got these kinds of pressures. Our quality scores are down in this area. We have whatever it happens to be. And we're still solving those things. We just happen to turn over here, and all of a sudden now our toolkit not only has screwdrivers and hammers, but it also has lasers and all sorts of other things. And,
True.
and we're going.
Although the one thing that I would love to see, and I have no insight into this, but here's an idea for ServiceNow. If they can incorporate their own LLM to be able to ingest, this is all the organizational stuff that we need to do. These are all the financial stressors on our organization. These are all the other qualitative stresses on our organization. Spit out the top 3 things that we need to do over the next quarter and give us some metrics on how to accomplish that.
I was talking to a former CEO of a large health system this week, and I took the 990 from that person's organization for a year and a half ago.
Yeah.
And I put it into ChatGPT. And I said, identify the stressors on the organization. And it did. And I said, what would be your, path forward? And because part of the thing is, I was talking to this person about how AI is going to fundamentally change healthcare. And I said, okay, these are the 5 things that ChatGPT recommended. And the CEO looked at me and said, yeah, that's right. That's what I would do. I'm like, yeah, it's amazing how quickly it can synthesize that much information and sort of look at it and say, look, these are the stressors on these organizations. And with those stressors, these are proven methodologies for approaching it. So what you're describing is very doable.
Yeah. I think you just have to figure out how to get those inputs and how to structure the organizations will interact with it. And quite frankly, if I was a principal at McKinsey or Accenture or any of these other consulting firms, I would be really frightened.
Yeah.
And I would be even more frightened if I was someone very junior in those organizations.
Yes. Oh yeah. No, I've paid for those teams of juniors to come out to my site and
$300 an hour plus.
Oh
to
yeah.
Come up with a PowerPoint for you.
Most of what they did was data collection. They gave them the problem set and then they met with people, they collected all the data and whatnot. Yeah, I'm concerned as well. Although people like yourself, a very specific skill set in a very specific space, that kind of consulting, I think, is going to do extremely well because people are trying to make sense of how AI is going to be applied in the practice of medicine, how it's going to be applied in the administration of health systems, and having that kind of knowledge set, I think, is distinct because I think the thing that makes it distinct is it's about moving people in an organization. It's about educating people. It's about changing hearts and minds and all that stuff. I'm not sure the large language models are changing hearts and minds yet.
The other thing that I think is my secret superpower is these large language models are really good at, especially within certain domains, coming up with insights. But connecting things across domains is still a bit of a vulnerability for them. I think it'll probably get better once they start actually seeing what those connections are. But what I do is I connect a lot of stuff between operations and clinicians and how Epic works, and tries to come together with something that's hopefully a little bit more novel than what you would get from kind of the standard recommendation.
John, I appreciate you coming on the show. I look forward to, I don't know, maybe we'll do this again next year. We'll see.
Absolutely.
We'll see what we're both doing around that time.
I think those UGM conferences are just going to be more and more like what we just saw.
Yeah, there's a lot to digest, a lot to talk about.
Yep.
Thank you for your time. If people want to get a hold of you, HIT Peak Advisors.
Right.
.com. All right. Thanks, John. Take care.
Thanks. Right.
Thanks for listening to the 229 podcast. The best conversations don't end when the event does. They continue here with our community of healthcare leaders. Join us by subscribing at thisweekhealth.com/subscribe. If you have a conversation that's too good not to share, reach out. Also, check out our events on the 229project.com website. Share this episode with a peer. It's how we grow our network, increase our collective knowledge, and transform healthcare together. Thanks for listening. That's all for now.